Ever wondered about the difference between a chalazion and a sty? Though they might seem similar, they are distinct conditions. A chalazion, a benign lipogranulomatous collection, arises from one of the meibomian glands lining the tarsal plate of the eyelid. In contrast, a sty originates from an infected hair follicle on the lid margin. A chalazion is the result of lipid inspisation in the meibomian glands. When these glands rupture, they release lipid into the surrounding tissues, causing a granulomatous inflammatory reaction. This condition is more common in individuals with underlying conditions such as rosacea, seborrheic dermatitis, or blepharitis, who are more prone to multiple and recurrent chalazia. The onset of a chalazion takes place over weeks, starting as a mildly to moderately tender red swelling of the upper or lower eyelid. The redness and tenderness eventually subside, but the lump remains. If left untreated, a chalazion may spontaneously resolve over several months. Now, how does one treat a chalazion? There are a few options, starting with conservative measures. These involve warm compresses and massage over the lesion for 3 to 5 minutes, twice daily. Topical antibiotic ointment such as chloramphenicol 1% is applied 4 times per day if there is significant redness, swelling or discharge. If cellulitis occurs, oral and occasionally intravenous antibiotics are prescribed. In cases where conservative measures fail, intralesional steroid injections present another option. Intralesional triamcinolone injections resolve chalazia in 75 to 84% of cases. The procedure involves an aseptic technique, topical anesthetic, and transconjunctival injection of 0.2 ml of triamcinolone. Patients are prescribed chloramphenicol ointment 1% 4 times per day for 5 days, with gentle massage for 5 minutes after each ointment application. A follow-up occurs in 3 weeks. If the chalazion recurs, additional injections may be required. Care must be taken to avoid perforation of the globe and to monitor for a steroid-induced rise in intraocular pressure. Incision and curettage is the third form of treatment. This technique includes the removal of the pseudocapsule surrounding the meibomian cyst. Excision of the pseudocapsule cosmetically debulks the tumor and reduces the risk of reaccumulation of meibomian secretion. Persistent chalazia, despite appropriate management and treatment, may indicate an underlying malignancy such as sebaceous cell carcinoma. In such cases, the diagnosis of chalazion must be reassessed and the curetting should be sent for histopathological examination. In summary, a chalazion is a benign lipogranulomatous collection that arises from the meibomian glands of the eyelid. It can be treated with conservative measures, intralesional steroid injections or incision and curettage. However, persistent chalazia may indicate an underlying malignancy and require further examination.